So now my topic is after completing anatomy of retina. Now I start with my topic diseases of retina. And the first topic is retinal vasculitis. Now what is retinal vasculitis? As the name suggests, retinal vasculitis is inflammation of retinal vessels, which may be primarily due to Ills disease. What is Ills disease? We will get to know in my upcoming slide, or it can be secondary to the any uveitis. Eels disease is very important part of your UG curriculum course of eye, and also it can come in your theory examination, in your PPG examination as an MCQ, and also as an MCQ in your theory examinations. So to start with, what is Ills disease? So what is Ills disease? So Ills disease is nothing but it is an idiopathic inflammation of the peripheral retinal veins. It is characterized by recurrent vitreous hemorrhage. This is a very important PPT question, MCQ question. It can also refer to as primary vitreous hemorrhage because the etiology is exactly not known. It is mostly idiopathic. Many workers consider it to be a hypersensitive reaction to the tubercular protein. Now, the clinical features of Ills, it consists of, it is a bilateral disease which typically affect young males, young adult, which are males. It can affect females also and old patient, but most commonly it occurs in young adults and males. The common presenting symptoms are sudden appearance of floaters, which means black spots in front of the eye. Here I would like to emphasize that floaters can occur in front of any patient's eye. So the different reasons for floater in any person's eye can be, first is musky irritants. What is musky irritants? In my vitreous class, I have already told you, whenever sometimes there are vitreous degenerations in our vitreous due to old age or due to myopia, it appears as floaters. These are physiological in nature. It can also appear as a floater, but some pathological reasons because of which floater occurs and which is a matter of concern. So first is vitreous hemorrhage. Vitreous hemorrhage in our eye, mild vitreous hemorrhage can appear as floaters in front of our eyes. A patient complaint of seeing black spot in front of the eyes if there is vitreous hemorrhage. Vitreous hemorrhage can be due to various reasons. One of the reasons of vitreous hemorrhage is Ills disease. Vitreous hemorrhage can also occur after sudden PVD or sudden RD or sudden trauma of because after which vitreous degeneration or PVD or RD occurs. So these are various reasons for floaters in front of the eye of the patient or black spot in front of the eye. So whenever a patient comes in your clinic with the complaint of black spots or floaters, we should think first for physiological reason or musculoskeletal, then we should do fundoscopy to rule out if there is any vitreous hemorrhage or any predisposing condition of PVD or RD, which can cause floaters, because these are some dangerous situations which can affect visual acuity in future. So proper screening of the eye is essential when a patient complains to you of floaters in front of the eye. Now the painless loss of the vision in the Ills disease is due to vitreous hemorrhage. Whenever vitreous hemorrhage is mild, it will appear as black floaters or black spot in front of the eye. But whenever vitreous hemorrhage is gross, it will appear as painless loss of vision. So it depends um, on the severity of vitreous hemorrhage. If it is mild, it will appear as black spot or floaters, and if it is vitreous hemorrhage is severe, it will appear as the painless loss of vision due to vitreous hemorrhage. The hemorrhage clears up, but recurrences are very common. Most of the Ills patients come very late because earlier they mostly just to look whenever previous episodes happens, with of mild vitreous hemorrhage, they overlook the condition and do not never show up to the clinic. But when they show up to the clinic, the situation worsens due to vitreous severe when it is severe vitreous hemorrhage causing loss of vision. Hence, Eels disease is detected very late in most of the cases, because in early stages, whenever it appears as black spot or floaters, patients mostly overlook the condition and they always come to the clinic at very late stages. Now, the clinical course of the Eels disease. Now, the clinical course of the Eels disease, it can come into a theory question. So, to start with, there are the 4 stages of the Eels disease. Now, the first stage is the stage of the inflammation. Now, the second stage is the stage of ischemia. Third stage is the stage of retinal neovascularization. And the fourth stage is the stage of sequelae. So depending on the which type of stage the patient is undergoing, the treatment also depends. So the treatment consists of diseases of medical treatment and laser treatment, laser photocoagulation, and vitreoretinal surgery. Now you will be thinking at what stage what treatment will be occur. So to start with, whenever there is vasculitis, first stage is the stage of inflammation. Here there will be the inflammation of the vessels. There will be no effect on the visual acuity and the patient will not complain of any floaters. So it mostly at this stage is mostly detected incidentally on routine fundus examination, where you will see vasculitis and sclerosed vessel. So at this stage, you should start the patient with medical treatment. Now, what is medical treatment? You should start the patient with oral steroids. At this stage, if we start with oral steroid, the inflammation will decrease and it will not progress. So here we can halt the progression of the Eels disease at the early stage of inflammation, where there is mostly no symptoms and there is always incidental finding of vasculitis on normal routine indirect ophthalmoscopy or fundoscopy. Now the second stage is a stage of ischemia. Whenever this stage, there is ischemia of the retina. Now the ischemia of retina occur in the gross vasculitis, where the choroidal there will be ischemia of the choroid and the retina. At this stage, the vascular endothelial growth factor will be released, which is known as VEGF. And this VEGF is responsible for the formation of the next stage, that is the stage of retinal neovascularization. So even at the stage of, if you detect a patient at the stage of ischemia, you should first, you will see vasculitis. At this stage also, patient will, there will be incidental finding and patient will never show up to the clinic by themselves. It will be detected incidentally. So if you ever see the patient with vasculitis, with gross vasculitis, you should go for FFA to see the ischemia on FFA. And if you see ischemia, to prevent the secretion of VEGF and to stop the progression of Eels disease to the third stage, that is the stage of retinal neovascularization, you should manage this stage of ischemia with laser photocoagulation. So at the stage of ischemia is always treated with laser photocoagulation to prevent this VEGF secretion. And at the stage of retinal neovascularization, if you see the stage of retinal neovascularization also, you will give laser treatment, but also to secrete anti-VEGF injections. Anti-VEGF injections, that is Avastin or bevacizumab. These are the injections or ranibizumab. These are the anti-VEGF injections. So if there is neovascularization has already started, you should also go for laser treatment also, and also anti-VEGF treatment. And at the stage of sequelae. Now, what is the stage of sequelae? This is the stage of complication which arises in the patient of Eels disease. And at this stage, the patient will have recurrent vitreous hemorrhage, which will cause which will cause gross vitreous hemorrhage, and sometimes can also cause fractional RD. So if the patient is coming to you at the fourth stage, that is the stage of sequelae with fractional RD or gross vitreous hemorrhage, you should not go for medical treatment or laser photocoagulation. We should go for vitreoretinal surgery. So this comes to here we comes to the end of is disease, its etiology and its management. Now, the vascular disorders of the retina. Now, after, as you all know, we have started with the disorders of the vessels. First, we deal with the retinal vasculitis, that is disease, which is primary retinal vasculitis. Now, we start with vascular disorders of the retina. Now, what are the various vascular disorders of the retina? Common vascular disorders of retina include retinal artery occlusion, retinal vein occlusion, diabetic retinopathy, hypertensive retinopathy, sickle cell retinopathy, retinopathy of prematurity, and retinal telangiectasia. So what are these? You will be like overwhelmed, but how many diseases are there? But when you get to know what each and every disease, it is very easy to understand various retinal vascular disorder. So when the central retinal artery or branch retinal artery occlude, it comes under retinal artery occlusion. Whenever any vein occlusion occurs, that is central retinal vein occlusion or branch retinal vein occlusion, it comes under category of retinal vein occlusion. And other important retinopathies are diabetic and hypertensive retinopathy. It is very common nowadays because most of our old people are suffering from diabetes and hypertension. So screening of diabetic retinopathy and hypertensive retinopathy is very important. And retinopathy of prematurity is also very important topic because the retinopathy of prematurity is dealing with the retinal abnormality or retinal disease in premature babies, and because it affects the future eyes of our future generation. Hence, these are the various important diseases of vascular disorders of retina. Now to start with occlusive disorders of retinal vessels. What are the etiology? Most common etiology of any occlusion, either retinal or vein occlusion, either branch or central, is most common patients etiology is patients suffering from hypertension and other cardiovascular diseases. Now, what are the common causes of retinal artery occlusion? So to start with, first, as we all know, why arteries are occluded? First, foremost important reason is atherosclerosis. Atherosclerosis related thrombosis. Then second is emboli. If there is any type of emboli, either it is fat emboli or various types of emboli, any emboli can cause artery, central retinal artery or occlusion or branch retinal artery occlusion. Other important etiologic factor for artery occlusion is retinal arteritis with obliteration. And that is inflammation of arteries. If a person is suffering from any arteritis, any disease related with arteries, it can cause branch artery occlusion, either branch or central retinal occlusion. Also, angiosperm, raised intraocular pressure, and thrombophilic disorders. Now, if intraocular pressure increases, if a patient is suffering from glaucoma, then also is prone to a central retinal or branch retinal artery occlusion. Now to start with central retinal artery occlusion. Now the central retinal artery occlusion. This is a very important topic theory wise also and practical wise also. Central retinal occlusion is one of the important ophthalmological emergency. Why it is emergency? Because if central retinal artery occlusion can cause permanent loss of vision, which permanent irreversible loss of vision. If so, hence, if a patient comes with central retinal artery occlusion, it is very important to identify the condition and manage the condition as soon as possible. Otherwise, it will cause some permanent irreversible loss of vision. So, what is central retinal artery? It occurs due to obstruction at the level of lamina cribrosa. Now, what are the symptoms? Symptoms are patient complains of sudden painless loss of vision. Now, what are the signs of this? Now, the signs, most important signs of central retinal artery occlusion is RAPD, relative afferent pupillary defect, or signs as direct pupillary light reflex is absent. And on ophthalmological examination, retinal arteries are markedly narrowed, but retinal veins look normal. So the most important feature of the central retinal artery is white fundus. The whole fundus will look pale. You have previously seen how our retina looks. It is pinkish in color. Now here we can see our retina is pale in color. Whole retina is pale. On all in central retinal artery, only macula appears red. It is because whole retina become pale due to obliteration of central retinal artery. Here, in this picture, there is not only macula appears red. There is a band of which appears red. This is because this is a special type of fundus where cilioretinal artery. This is a patient of CRO with cilioretinal artery. Cilioretinal artery is very important artery which occurs in mostly 20% of the population. So if a person is having cilioretinal artery, which is supplying macula, 80% of population do not have cilioretinal artery. Only 20% population have cilioretinal artery. So cilioretinal artery supplies macula. So if a patient is having CRO, normal CRO, if a patient without cilioretinal artery is having CRO, whole retina will appear pale. This area also, only macula will appear red and will cause permanent loss of vision because there will be ischemia of macula also. But if your patient is having cilioretinal artery, so the macula will not undergo ischemia and whole retina will undergo ischemia, hence visual acuity will be there. So this is that type of example. The fundus photograph showing marked retinal pallor in acute central retinal artery occlusion with sparing of territory supplied by cilioretinal artery. Otherwise, in a case of CRO, there is a whole pale retina with a cherry red spot. So this is an MCQ question. Cherry red spot is macula which appears red and the background of pale retina in CRO. So this is an MCQ question which can come in your pre-PG and MCQ examination of theory also. Now the retina becomes milky with white due to edema. Central part of the macula area shows cherry red spot due to vascular choroid shining to the thin retina of this region. So why does our macula appears cherry red? Because in macula is the thinnest part of the retina and whole retina becomes pale, the thickest retina become pale and the thinnest retina also become pale, but because of it is the thin part, the underlying choroid shines away and the background of the white pale retina in the central retinal artery occlusion. So this is the characteristic feature of central retinal artery occlusion, cherry red spot at macula because of the underlying vascular choroid shining through the thinnest retina of the region. In the eyes with cilio-retinal artery, part of the macula will remain normal. I already told you in the previous slide, if a patient is having cilioretinal artery, then macula will be normal because it is an accessory artery which supplies macula, which occurs in only 20% of the population. So they are lucky people, and even if they undergo central retinal artery occlusion, their visual acuity will not hamper, which is very rare. But most commonly, central retinal artery occlusion is an emergency condition, and in a patient who do not have cilioretinal artery, macula will undergo ischemia, and visual acuity will be permanently, irreversibly lost. Blood column within the retinal veins is segmented, and this is known as cattle tracking. This is again another important sign of central retinal artery occlusion. So these are the features of central retinal artery occlusion. Symptoms, what are the symptoms? Patient will come with sudden diminution of vision. It will be painless in nature. And what are the signs which will look for? Visual acuity will be PL or mostly sometimes if it is very late, PL will be absent. Sometimes PL will be present if it is early. And there will be RAPD or reaction will be absent. And when we will dilate the fundus, then we will be seeing on fundoscopy pale white retina with cherry red spot and macula. And I have told you the reason behind this. In your pre-PG examination, MCQ examination, other reasons for cherry red spot in the retina will be asked. And other cherry red spot conditions are storage disorders. You should know this. So this is, I'm giving you some extra knowledge. You should go and read it. So right now it is not in the scope of my this lecture, so I'm just skipping it. Now, after central retinal artery occlusion, there's branch retinal artery occlusion. Now, what is branch retinal artery occlusion? It usually occurs following lodgement of the embolus at bifurcation. Now, the retina distal to occlusion become edematous with narrowed arterioles. Later on, the involved area is atrophied, leading to permanent sectoral visual defect. Here, visual defect will be not gross as like CRO, because central retinal artery is the main supplying artery of the whole retina. Hence, it will lead to gross visual acuity diminution. But in branch retinal artery occlusion, there will be there will be visual defect, but it particular sectoral defect, and it will be not as gross as in CRO. Now this is a diagrammatic picture. Here we can see pink retina, and here we can sectoral pale retina. So the sectoral pale retina here which denotes the artery which is blocked. So supratemporal branch retinal artery occlusion. So this here we can see supratemporal artery is occluded, and there is thinning of arteries also distal to it. Here central supratemporal retinal artery is occluded with there is thinning in the arteries, and because it is always also involving macula, there will be diminution of vision, but it would be not gross, and there will as like in central retinal artery occlusion, and pupil will also not affected. Now the this is the picture of the fundus showing supratemporal branch retinal artery occlusion, that is branch retinal artery occlusion. Now here we should note the retinal pallor and supratemporal area and whitish emboli on the optic disc and in the superior temporal branch of the retinal artery. Now the management. In the central retinal artery occlusion, the immediate lowering of the intraocular pressure, because it is emergency. So it is a medical emergency. So what should we do in central retinal artery occlusion if a patient comes with it? We should immediately do lowering of intraocular pressure. It can be done by intravenous mannitol, intermittent ocular massage, paracentesis of anterior chamber. Also by vasodilators and inhalation of the mixture of 5% carbon dioxide and 95% oxygen, which is known as carbogen. Also by giving anticoagulants and intravenous steroids. But mostly these are all controversial, and it is very important to lower down intraocular pressure in CRO, and also the massage, intermittent ocular massage can be done by goniolens. So these are the various measures which should be done if a patient comes on as an emergency patient with central retinal artery occlusion. Now the retinal vein occlusion. Retinal vein occlusion more common than the artery occlusion. It occurs mostly in elderly patient in 6th or 7th decade. Etiology: pressure on the vein by sclerotic retinal artery, and also by the hyperviscosity condition of the blood, like hyperhomocystinemia, high lipid, etc. causes hyperviscosity of blood, or periphlebitis retina, raised intraocular pressure. Local causes are orbital cellulitis, facial erysipelas, and cavernous sinus thrombosis. Now, central retinal vein occlusion is again divided into ischemic central retinal vein occlusion. Non-ischemic central retinal vein occlusion. Now, BRV, branch retinal vein occlusion, is again other type of retinal vein occlusion. So now central retinal vein occlusion is divided in two types: ischemic and non-ischemic type. Non-ischemic CRVO, that is known as venous stasis retinopathy. Most common clinical variety is 75%. And it is associated with mild to moderate visual loss, whereas ischemic CRVO is associated with severe visual loss. So mostly non-ischemic CRVO is always having better prognosis than ischemic CRVO, as you all know, as the name suggests. Now, the early cases of CRVO will have mild venous congestion and tortuosity, and few superficial flame-shaped hemorrhages, and more in peripheral, which is more in peripheral retina. with mild disc edema or mild to or no macular edema. Whereas in late cases, which occurs mostly after 6 to 9 months, there appears shedding around the main veins and a few pseudoretinal collaterals around the disc. Retinal hemorrhages are partly absorbed. Macula may show chronic cystoid edema in moderate cases or may be normal in mild cases. Now this is the central retinal vein occlusion of non-ischemic type. Here, this is very important PPT and MCQ question. How CRVO fundus look? CRVO fundus will have papilledema or disc edema with multiple superficial hemorrhages and all quadrant, which is more vigorous in ischemic type. How CRVO and ischemic type fundus look? I will tell you in my upcoming slide. Now this is the fundus picture of central retinal vein occlusion of non-ischemic type. Here you can see there is disc edema also. There are mild tortuosity of vessels with multiple hemorrhages in all quadrants with macular edema. But the visual loss will be not as gross as in the ischemic CRVO. And here pupil will also not affected. Whereas in ischemic CRVO, RAPD will be present and visual loss will be gross. Whereas in non-ischemic CRVO, visual loss will be not as gross in CRVO and pupillary reaction will be normal and macular edema will be also less than ischemic CRVO. Hence, CRVO of non-ischemic type have better prognosis. Now, the ischemic CRVO, also known as hemorrhagic retinopathy, refers to the sudden, acute, complete occlusion of the central retinal vein. It is characterized by the marked sudden visual loss. Fundus examination in early cases have massive engorgement, congestion, and the tortuosity of the retinal veins, massive retinal hemorrhages. Almost whole fundus is full of hemorrhages, giving a splash tomato appearance, numerous soft exudate, and papilledema. These are the characteristic features of ischemic CRVO. Macular area is full of hemorrhages and is severely edematous. In late stages, ischemic CRVO will show marked sheathing around veins and collaterals is seen around the disc. Neovascularization may be seen at the disc, NVD. NVD is term and NV is term which will be coming in diabetic retinopathy also again and again. So you should know what is the meaning of NVD and NVE. So neovascularization at the disc is NVD and neovascularization at the elsewhere anywhere in the retina is NVE. So it is it can be seen in any condition with ischemia. So as we all know, CRVO will cause ischemia of the retina. So we can see numerous NVDs and NVs in the fundus. Now the macula shows marked pigmentary changes and chronic cystoid edema. Now this is the picture of central retinal vein occlusion of ischemic type. You can see the difference between this picture and this picture. This is non-ischemic type with very less hemorrhages. Here it is very gross, superficial hemorrhages, retinal hemorrhages, which is very vigorous looking. So it is tomato splash appearance, ketchup appearance. So this is the characteristic feature of this ischemic retinopathy, which occurs in all quadrant with disc edema. Treatment. Pan-retinal photocognition or cryo application if the media is hazy may be required to prevent neovascular glaucoma in patient with widespread capillary occlusion. Now, what is the treatment of ischemic CRVO or non-ischemic CRVO? Most commonly, it is pan-retinal photocognition because in both the cases there will be ischemia. In ischemic CRVO, there will be more ischemia, but in non-ischemic also there will be some percentage of ischemia. So pan-retinal photocoagulation and cryo application, if media is hazy, may be required to prevent neovascular glaucoma in patient with widespread capillary occlusion. So what are the differences between ischemic CRVO and non-ischemic CRVO? In both, in first, visual acuity will be more lost in ischemic as compared to non-ischemic. Then pupillary reaction will be having RAPD in ischemic, non-ischemic can have normal pupil. There will be superficial hemorrhages, which will be more marked in ischemic CRVO. Macular edema will also be more marked in ischemic CRVO, and this condition will be reversible as compared to non-ischemic CRVO, which can be reversed by PR, pan-retinal photocoagulation, and anti-vascular endothelial growth factor injection like Avastin, Bevacizumab. So hence non-ischemic CRVO is more vigorous than ischemic CRVO is more vigorous than non-ischemic CRVO. Now, the photocoagulation should be carried out when most of the intraretinal blood is absorbed, which usually takes about 3 to 4 months. Now, after central retinal vein occlusion, we come to supratemporal branch retinal vein occlusion. Now, what is after central retinal vein occlusion? BRVO. So, this is a type of, it can be also type of infratemporal branch retinal occlusion according to the type of vein occluded. Either it can be supratemporal, infratemporal, supranasal, infranasal, but according to the type of vein branch of vein occluded, that can be type of BRVO. So branch retinal vein occlusion, how can it, most of the features is like CRVO, but it will occur in particularly quadrant. So this is the example of branch retinal vein occlusion occluding supratemporal retinal vein occlusion. So here a sector, again like branch artery occlusion, a sector will involve and will be having a feature of CRVO. Not in all quadrants, it will involve one quadrant according to the type of vein involved. So it will also have superficial hemorrhages, and if it is occurs in temporal part, either infratemporal, supratemporal, and as we all know, macula is temporal to the disc. So edema, macular edema will be associated with this superficial hemorrhage, and BRVO will be having macular edema, which will be the main reason for diminution of vision. Here, disc edema will not be there like CRVO, and visual acuity will be not as much lost as in CRVO, and pupillary reaction will be normal. And great photocoagulation may be required in patient with chronic macular edema. An anti-VEGF injection can be also given if a BRVO is associated with macular edema. In patient with neovascularization, scatter photocoagulation should be carried out. Now, hypertensive retinopathy. Now we have done with vasculitis and other vessels disorder. Now hypertensive retinopathy, again a disorder of vessels of retina. It is retinal vasculature changes and fundus changes which occurs in a patient with hypertension. So it refers to the fundus changes occurring in patients suffering from systemic hypertension. Three factors which play a role in the pathogenesis of hypertensive retinopathy are vasoconstriction, arteriosclerosis, and increased vascular permeability. Reading of hypertensive retinopathy, Keith and Wegener retinopathy, it was given in 1939. It is so whenever it is why this first of all I will like to tell you why it is important to know hypertensive retinopathy, because most of the patient you will get, it will be referred from medicine department to auxiliary department for the grading. And why this grading is very important, because the grading of hypertensive retinopathy will be associated with the severity and chronicity of the hypertension in the patient. Hence, a patient which is recently diagnosed hypertension or diabetic patient is mostly referred to ophthalmology OPD for fundus examination, because by noting down the grading or severity of hypertensive or diabetic retinopathy, medicine patient can easily associate the chronicity and severity of the disease, either hypertension or diabetic, in the patient. Hence, the importance of hypertensive retinopathy and diabetic retinopathy screening is nowadays very important, because hypertension and diabetes are nowadays very prevalent among population. So, what is grading of hypertensive retinopathy given by Keith and Wegener? First grade, grade 1, generalized arterial attenuation. Here you can see arteries are mildly attenuated, broadening of arterial light reflex, and venous concealment. Here you can see there is broadening of arterial light reflex, and the vein below it is concealed, it is lost. Now the grade 2, it is generalized narrowing and focal attenuation of arteries associated with deflection of the veins. Here you can see at the AV crossing, artery and veins are crossing, deflection of vein at arteriovenous crossing, Seller's sign. This is a very important sign, and it occurs in grade 2. Now the grade 3, This consists of grade 2, all the changes of grade 2 plus copper wiring of the arterioles and banking of veins distal to AV crossing, that is known as bonnet sign, and tapering of veins on the either side of the crossing, that is gun sign, and right angle deflection of the veins at the AV crossing is known as Salus sign. So bonnet sign, gun sign, and Salus sign. These are very important. Now the flame-shaped hemorrhages and cotton wool spots and hard exudate can also be present at this bleeding. Now here is a diagrammatic picture, bonnet sign, and this is flame-shaped hemorrhages, cotton wool, hard exudate. Here you can't see bonnet sign and gun sign. Yeah, here there's a thinning, you know, and here you can see banking of vein distal to the AV crossing. This is B for B banking, bonnet sign, Salus sign, deflection of our veins. So these are the features of grade 3 hypertensive retinopathy. Now the grade 4 hypertensive retinopathy, with this consists of all changes of grade 3 plus silver wiring of arterioles. Here you can see there is silver wiring of arterioles with hard exudate, which are all the staging of grade 3 characteristic features of grade 3 is present with silver wiring and disc edema. This is the grade 4 hypertensive retinopathy. Now the hypertension with involutionary saline sclerosis, this is other reading. Hypertension without sclerosis, hypertension with compensatory arterial sclerosis, and malignant hypertension. So this is why hypertensive retinopathy is very important. Now diabetic retinopathy. Diabetic retinopathy is very important practically and theoretically also. You should understand, and nowadays it is very important to know and how to screen it. So diabetic retinopathy, it refers to retinal changes seen in patients with diabetic mellitus. With increase in life expectancy of the diabetics, the incidence of diabetic retinopathy has increased. In Western countries, it is the leading cause of blindness. Now, the risk factor associated with occurrence of diabetic retinopathy are duration of diabetes is the most important determining factor. Roughly 50% of patients develop diabetic retinopathy after 10 years and 70% after 20 years and 90% after 30 years of onset of disease. Now, the gender-based incidence is more in females than males. Poor metabolic control is less important than duration, but nevertheless relevant to the development and progression of diabetic retinopathy. Hereditarily, it is transmitted as recessive trait without any sex linkage. The effect of heredity is more on proliferative retinopathy. Pregnancy is another more important reason for diabetic retinopathy. It may accelerate the changes of diabetic retinopathy. Hypertension, when associated, may also accentuate the changes of diabetic retinopathy. Other risk factors, including smoking, obesity, and hyperlipidemia, can also increase the severity of diabetic retinopathy. Now, the classification of diabetic retinopathy has been variously classified. Presently followed classification is as follows. First is NPDR, non-proliferative diabetic retinopathy, which is divided into mild NPDR, moderate NPDR, severe NPDR, and very severe NPDR. Then comes proliferative diabetic retinopathy, then with diabetic maculopathy, and fourth is ADED, that is advanced diabetic eye disease. The NPDR, PDR, ADED, DME, these are the various mnemonics which will come again and again. So you should know what are this. NPDR is non-proliferative diabetic retinopathy, PDR is proliferative diabetic retinopathy, DME is diabetic macular edema, and ADED is advanced diabetic eye disease. Now, what is non-proliferative diabetic retinopathy? Non-proliferative NPDR diabetic retinopathy, ophthalmoscopic features of NPDR include microaneurysm in the macular area, which is the earliest detectable lesion. It comes in your PPG MCQ question. What is the earliest signs? Detectable lesion in retina in diabetic retinopathy is microaneurysm. Now, the retinal hemorrhage, both deep and dot and blot hemorrhage and superficial hemorrhage is the another characteristic feature of NPDR. Now the hard exudate yellowish white waxy looking patches are arranged in clumps or in circinate pattern. These are most commonly seen in macular area, and this is known causes diabetic macular edema. Retinal edema is characterized by retinal thickening. Now, what is cotton wool spot? This is cotton wool spots are the spots which occurs due to ischemia of RNFL. This is the definition of cotton wool spot. If it is occurs in more than 8, then the patient is at high risk of developing PDR. Now, the other venous abnormalities like venous bleeding, looping, and dilatation is also associated with diabetic retinopathy. Again, intraretinal microvascular abnormalities, IRMA is also associated with diabetic retinopathy. Dark blot hemorrhages, blot hemorrhages presenting hemorrhages, retinal infarcts. So now these are the various lesions associated with NPDR. First is microaneurysm. I will again revise it. Then retinal hemorrhage, which can be deep dot and blot hemorrhages, which is occurs in OPL and INL level, and superficial hemorrhages, which is flame-shaped hemorrhages, which occurs in the RNFL layer, that is the retinal nerve fiber layer. Then other features are hard exudate, which is yellow whitish waxy coating, which occurs at the junction of edematous and non-edematous retina, and it occurs at the level of OPL, that is outer plexiform layer. We should know the causes of each and every lesion. Like microaneurysm, it occurs due to dilatation of arterioles, capillaries, and is very leaky, which causes hard exudates. Hard exudate occur due to leakage of this microaneurysm at the macular level, and occurs at the level of outer plexiform layer. When various hemorrhages, which I have told you, and dot blot hemorrhages, superficial hemorrhages. Dot blot hemorrhages are mostly occurs at the deeper level, hence the sizes dot and blot type, and superficial hemorrhages occurs at the flame-shaped hemorrhage at the level of nerve fiber layers. Hard exudate yellowish white waxy coating. This hard exudate occurs at the outer plexiform layer and occurs in the patches and clumps. So we have revised the various types. We are revising the various lesions associated with diabetic retinopathy. Cotton wool, I have told you that due to ischemia of the nerve fiber layer, and other venous abnormalities like bleeding and looping and dilatation, and IRMA, that is intraretinal microvascular abnormalities. Here the retina and choroid are abnormal vessels occurs in between retina and choroid. This is known as intraretinal microvascular abnormalities. And dark blot hemorrhages represent hemorrhagic retinal infarcts. So these are various lesions: microaneurysm, hard exudate, soft exudate, cotton wool, venous abnormalities, IRMA, dot blot hemorrhage, superficial hemorrhages. These are various abnormalities which are associated with diabetic retinopathy. So to start with NPDR, which is mild grade. Mild NPDR, how it is defined, at least one microaneurysm. Here you can see some microaneurysm which appear at the macular level or intraretinal hemorrhage, and hard and soft exudate may or may not be present. Then the patient is mild NPDR. Now the moderate NPDR, moderate microaneurysm, intraretinal hemorrhage, early mild IRMA, and hard soft exudate may or may not be present. Here you can see all the lesions. This is hard and soft exudates and microaneurysms, which are very fine. Severe NPDR, any one of the following 4-to-1 rule: 4 quadrants of severe microaneurysm, intraretinal hemorrhages. So what is 4-to-1 rule? A patient is known to have severe NPDR if you have any one criteria of this 4-to-1 rule. Any one criteria of this 4-to-1 rule. What does this mean? For either 4 quadrants of severe microaneurysm is present, or intraretinal hemorrhages is present, or 2 quadrants of venous bleeding is present, or 1 quadrant of intraretinal microvascular abnormality is present. So this is how patient of severe NPDR will look with all these characteristics with any one of 4-to-1 rule. Now, very severe NPDR, any two of the following of 4-to-1 rule of, I have told you earlier, in severe NPDR, any one, and in very severe NPDR, any two of 4-to-1 rule. That 4-to-1 rule of, what does it mean? 4 quadrant of severe microaneurysm, intraretinal hemorrhages, and or 2 quadrant of venous bleeding, or 1 quadrant of intraretinal microvascular abnormalities. Proliferative diabetic retinopathy. Proliferative diabetic retinopathy develops in more than 50% of cases after 25 years of onset of disease. Therefore, it is more common in patients with juvenile onset diabetes. The hallmark of proliferative diabetic retinopathy is the occurrence of neovascularization over the changes of very severe non-proliferative diabetic retinopathy. It is characterized by proliferation of new vessels from the capillaries. So what is the PDR? The hallmark of PDR is the occurrence of the neovascularization over the changes of very severe NPDR. And it is characterized by proliferation of new vessels from the capillaries. Now, it is characterized by NVD and NVE, which I have told you earlier in the CRVO. So it is neovascularization of disc or neovascularization of elsewhere, usually along the course of major temporal retinal vessels. These new vessels may proliferate in the plane of retina and spread into vitreous as vascular fronts. This vascular fronts causes vitreous hemorrhages. Later on, condensation of connective tissue and the new vessel results in formation of fibrovascular epiretinal membrane. So epiretinal membrane is another feature in diabetic retinopathy. Vitreous detachment and vitreous hemorrhage may occur in this stage. Now, that was other classification diabetic retinopathy is the Drs classification, which occurs for PDR without HRC, that is high risk characteristic, which means early PDR. This is the picture showing early PDR. Second is PDR with HRC, that is high risk characteristic, which includes advanced PDR. High risk characteristics of PDR include either all of three, one of all the three. NVD 1/4 to 1/3 of disc area with or without vitreous hemorrhage or pre-retinal hemorrhage, or NVD less than 1/4 disc area with vitreous hemorrhage or pre-retinal hemorrhage, or NVE more than 1/2 of the disc area with vitreous or pre-retinal hemorrhage. So this is the diagrammatic representation of PDR with HRC, that is proliferative diabetic retinopathy with high risk characteristics. Here we can see NVD, NVE, vitreous hemorrhage, etc. On diabetic maculopathy occurs in diabetic retinopathy. All changes in macular region need special mention due to their effect on vision. These changes may be associated with NPDR also and PDR also. The diabetic macular edema occurs due to increased permeability of the retinal capillaries, as we have seen in microaneurysm, which leaks, which causes accumulation of hard exudate at macula. It is termed as clinically significant macular edema. This is very important definition, and you should know what is the definition of CSME. If one of the following three criteria are present on slit lamp examination with 90D lens, we say it cystoid, clinically significant macular edema. It is different from cystoid macular edema. So what are the three conditions for clinical significant macular edema? If one of the following three criteria are present on slit lamp examination with 90D, first is thickening of retina at or within 500 micron of the center of the fovea, or hard exudate at or within 500 micron of the center of the fovea associated with adjacent retinal thickening, and development of a zone of retinal thickening of 1 disc diameter or larger in size, at least a part of which is within 1 disc diameter of the foveal center. So again, I will repeat the three, either one of all the three criteria. If any one of the present, the patient is clinically significant macular edema. First is thickening of the retina at or within 500 micron at the center of the fovea, hard exudate at or within 500 micron of the center of the fovea associated with adjacent retinal thickening, and third is development of a zone of retinal thickening 1 disc diameter or larger in size, at least a part of which is within 1 disc diameter of the foveal center. So this is how succinate retinopathy or diabetic retinopathy seen here. Hard isolated are located in succinate pattern. Focal exudative maculopathy, it is characterized by macroaneurysm, hemorrhages, macular edema, and hard exudate, which are usually arranged in succinate pattern. So I have shown you the picture. Now the fluorescein angiography reveals focal leakage with adequate macular perfusion. So the treatment of focal exudative maculopathy is focal macular laser. Focal laser. Now, the diffuse exudative maculopathy, it is characterized by diffuse retinal edema thickening throughout the posterior pole with relatively few hard exudate. Fluorescein angiography reveals diffuse leakage at posterior pole. Hence, the treatment of diffuse macular edema is macular laser, grid laser, focal laser for focal maculopathy, grid laser for diffuse maculopathy. Now, the ischemic micropathy, it has worse prognosis. So, it is very important to distinguish ischemic maculopathy from other maculopathy. It occurs due to microvascular blockage and has worse prognosis. It is detected in FFA. It is clinically, it is characterized by marked visual flaws in microaneurysm with hemorrhages